Okay, so I'll be presenting Dr. Forcht Dagi, who's going to be presenting at Grand Rounds today for, I think, the second time this year. We're lucky to have him, but I'll go through some of the updates. If you can go to the next slide. The next few slides are our conferences throughout the week that Dr. Quinones always presents. You have the epilepsy conference and the spine conference, which are today. And then the neuro-oncology on Thursday, neurovascular on Thursday at the same time, as well as the movement disorder. And then on Friday, we have the neuro-oncology teaching conference. Obviously, all those conferences have CME credits with them. They're all closed except for the Friday conference. And then the next slide is on the Mayo Clinic Florida 35th anniversary. Dr. Quinones has presented this on the last couple of weeks, so we'll be brief, but basically this is the rendering of what's going on over the years since the founding of this site over the last 35 years. And then we have opened the operating rooms recently, and the IMRI is coming in the next week or so. So around the globe, Dr. Quinones received this Distinguished Researcher Award last week from Mayo Clinic Florida, selecting the highest impact researchers on campus, and he was selected one of those. Next slide. Linda, I saw you on there. Can you comment on this top box score?
Yes, thank you. We are so excited about this. This is what really kind of means a lot for us when we take a look at patient satisfaction. If you take a look here, we say we want to live within the swim lanes, which is the orange and the green, but if you can see here that we've surpassed that for the past few quarters. So that's quite impressive. This is the highest likelihood of recommending the practice in 3 years. So we're super excited about these scores and very congratulatory for our team here.
Great. And then Dr. Notmeyer or Dr. Pierce, I don't know if you're online, if you can talk about your conference at NASS.
Yeah, this was an Ask the Expert segment on robotic surgery. And so Steve and I both participated in this. It's you can see it online also through that link. It's about maybe a 5 to 10 minute discussion Steve and I had concerning the future of robotic surgery.
I think when I'm using navigation to put screws in, I'm also using navigation beyond that in the case for, sometimes put the interbody cage in and navigate in patients who have previous laminectomies to try to stay out of the dura. And, some of the current robotic systems do allow navigation beyond the screw placement, some of them don't. And so when we look at the cell phone and how that has progressed.
Great. Yeah, if anyone wants to see that further, you can get a copy of that link off the screen there, or contact one of our people around the conferences.
Great.
I think.
And then this is from Mission Brain, from the Lisa Hannigan Humanitarian International Neuroscience Scholarship that Dr. Quinones has presented based on Lisa Hannigan, who recently passed away from a traumatic brain injury. Next slide. And this is the chapter program. I think, Michael, can you comment on these next few slides?
Yeah, the chapter program is a great thing that Mission Brain just launched. It's connecting medical students, undergraduate students, physicians, mentors from all around the globe. We have all kinds of great events coming up. As of right now, we have over 35 chapters from, I believe, 10 countries at this point. So please stay updated. Go to missionbrain.org and look at the chapter link if you want to learn more, or feel free to email me. Thanks.
Great. Next slides. This is the International Fellowship. Next slide. And then these are the recent published studies. This is from Journal of Neuro-Oncology, led by Dr. Akinduro and Dr. Abodi, on focus versus conventional radiotherapy for spinal oncology. Next slide. This is a paper in Cell Reports led by Dr. Rosenfeld, talking about different signaling pathways for glioblastoma. Next slide. And then this is from Hannah Brown, who's a collaborator from Purdue University, who was accepted as the highest scoring abstract at SNO for using interoperative evaluation of IDH mutation status. And this is ResearchGate. To be honest, I don't really know much about this. Is Adrian online?
Yes, good morning. Exactly. So these are new updates regarding the score of the different teams. So the faculty, the fellows, the residents, and we are trying really to promote this type of platform in order to reach the different in this case, shields of the Mayo Clinic. This is an achievement of this paper of Dr. Q with Dr. Jen, Dr. Chan, and Akinduro. And what we can see, it reached the 20 reads. And so please share with me also any other achievement or weekly report that you want to send so we can feature them in the next lecture series.
So out of curiosity, what's the biggest difference between this and an H index?
So actually, this is more a social network score and it takes into consideration different parameters, like, for example, the reads that your article received, the recommendation it received. So it's quite different in the sense that maybe takes more in consideration the social impact of the article on, in this case, a different line platform, on the ResearchGate platform. And the score usually changes very quickly. Every week there are updates regarding the score. So I think it's a great opportunity to increase the visibility of the different work that the people does. So it's important to promote that in this sense.
Great. So we should be tweeting or whatever all our papers.
Exactly. Yeah. The idea is to try to publish. I mean, usually ResearchGate recognize this article directly from your let's say publications. So it's important to, for example, try to follow the most important the persons. Let's say try to recommend the different article. It's like a Facebook of the journals of the article. So it's a way in this case to increase the visibility of the different research items. So also sharing the different achievement and the weekly reports could be a great way in this case to increase the visibility of every author of present in ResearchGate. So please subscribe if you have not subscribed, and of course try to be active and send me any type of achievement and weekly reports so that we can show them to all the platforms.
And this is LinkedIn and YouTube, which are probably along the same line, I assume.
Exactly. Yeah. So this is actually a new channel. We just opened that 2 weeks ago. We are trying to upload the different contents of the Monday and the Fridays, dividing them in different themes and so try to catalog them as an online journal. So we are working on that, and we're very excited to promote this type of online platform, as also LinkedIn that you showed before.
Great. Okay, next slide.
Thanks.
No problem, new members. Linda, can you comment on Shannon?
You bet. Yeah, I just wanted to share with the group that Shannon has accepted the position for a medical staff assignment coordinator, which is basically our MSAC in short. And we're really excited about this. We hosted a pilot over the past 6 months, and she has done an incredible job for the Department of Neurosurgery and the Department of Neurology. As you all know that are on this call, we can't do what we do without making sure that the patients get in to see us. And she's done an incredible job with getting our calendars out in a timely fashion. She worked quite closely with our MAAs and our schedulers, but she helped to increase the visibility for neurology for 3 months out and for neurosurgery for 2 months out. So this is an incredible job by Shannon. And Shannon, I don't know if you're on the call or not, if you have anything else to add.
Not really. Just really excited to be doing this. And just one quick note, neurosurgery, we're actually 3 months out, and they are looking at making that sort of an unofficial pilot to see if we can get the other surgical departments out 3 months out as well. So if this works for us, they might be making it clinic-wide for Florida if that works for the other departments too. So that's really exciting.
Great work, incredible work, because if we can get our schedules open 3 months out, that'll allow the patients who leave here to actually get scheduled for follow-up visits, post-surgery, et cetera. So kudos to you. We're so glad that you're accepting this position as the MSAC moving forward. Thanks, Shannon.
Thank you.
Great. Next slide. This is the Latin America Talk Essentials that I think is bi-monthly, headed by Dr. Quinones, Dr. Sheehan, and Dr. D'Amico. These are special guests, 2 of which are Hopkins ex-residents or current residents, and Henry plays a pivotal role in that. So, and as well as Andrea and Andres. Next slide. And then this is Chris online? Anyways, this is the same slide.
Yeah,
Oh,
I'm
go
here.
ahead.
Okay, sorry,
Go ahead, Chris.
technical
No problem.
issues. Yeah, so we're coming into the last couple of days of the month. I want to congratulate Sanjeet for what looks like a very robust effort this year. And please get your funds into Kevin. And then what we're going to do is I'm going to send out an email this morning, but everyone will take a selfie and send it to Kevin, and he'll circulate that through our judges as the month comes to a close, and we'll decide who gets to pick where the money goes in terms of which charity. So thanks everyone very much for participating.
Great. Next slide. And this is the walleye tank that will be on December 3rd, 2021. Dr. Talk and his team will be presenting at that. Next slide. This is the Mayo Clinic and Georgia Tech Convergent Science Program presentations. It's going to be held on Friday, December 3rd. And these are the mentors, and Dr. Talk as well as Dr. Wilkie have projects being presented there. Next slide. Upcoming lecture series, as you can see below. Next slide. Clinical trials, and so these are the same 17 clinical trials we've been presenting, and you can just go through those slides quickly. Great, thanks, Gaetano. Okay, so now to our featured presentation, Dr. Teo Forcht Dagi. So I have the honor and privilege of introducing Dr. Dagi, who's really truly a renaissance man within the field of neurosurgery. Not only has he accomplished a lot clinically, as you can see here, he has trained and worked at several institutions, not only across the United States, but across the world. You can see he received his MD at Johns Hopkins. He was trained at Mass General, has a MBA from Wharton at UPenn. Has had several professorships, including Medical College of Georgia, MIT in Northern Ireland and Lithuania, in Boston, and currently is one of our professors of neurosurgery at Mayo Clinic at the enterprise level. He's accomplished a lot, not only clinically, but also research-wise, entrepreneurship, and among the social aspects of medicine. We rely a lot on him for our residents to provide guidance and direction. So you can go to the next slide. And here's just some of the selected publications that are high impact. Dr. Dagi.
So, sorry, Dr. Chinchan, I just called Dr. Dagi. He is connecting right now.
Okay.
Hey, Andre, he's aware, right?
Yeah, I just called him a couple times. He just had a quick meeting before the lecture, so he's just connecting right now.
Just join us, sir. Great. Dr. Dagi, you're muted. Good morning.
Good morning, everybody. Apologies for keeping you waiting. Can you see me all right?
Yes, sir.
Great. Let me share my screen. And we should be ready to go. Okay, ladies and gentlemen, honored guests, thank you very, very much for joining me this morning. This to me is one of the most interesting areas in the neurosciences. Today we're going to speak about non-invasive neuromodulation, which is, of course, a subset of neuromodulation in general for psychiatric conditions and related indications. The history of this area really parallels the history of what we now call modern neurosciences. And it's really impossible to talk about without also acknowledging all the work that has been done in the area by people who never would have thought of themselves as neurosurgeons or neurophysiologists or neuroanatomists, but just thought of themselves as physicians trying to understand the nervous system, or in some cases, as good scientists.
Sir, sorry for interrupting you. Do you mind sharing in presentation mode, please?
I'm sorry, say that again?
Do you mind using presentation mode, sir, for the PowerPoint?
Sorry, I thought we had. How is that? Can you see that better?
Thank you. Thank you.
Great. Thank you very much. So sorry. Thank you very much. What I'd like to do over the next half an hour or so is take you through the story of non-invasive neuromodulation for psychiatric conditions and for related indications. This is going to take a little bit of history and a lot of medicine and a lot of concepts about how the nervous system works and what disease really is. We call that nosology. But it's worthwhile because it takes you to an understanding of an area which is becoming really increasingly interesting and increasingly important. We're going to start in Bologna, in Italy, at the end of the 18th century. There was then an interesting model that said, if you want to understand the nervous system, do two things: stimulate it electrically and work on condemned criminals who had been hanged or decapitated. Giovanni Aldini, who was the cousin, it turns out, of, the nephew of Luigi Galvini, from whom the term galvanize comes from, electrically stimulated the exposed cerebral cortex of executed prisoners, whether they were decapitated or later hanged. In 1804, he noted that cortical stimulation evoked facial grimaces and concluded that the cortical surface could be electrically stimulated, and somehow made the jump to say electricity could have therapeutic effects, including neurological and psychiatric disorders. To the right, you see some of the instruments that were available for galvanic stimulation in 1804. In 1818, a book was published called Modern Prometheus. Some of you may know it. The manuscript is on the left, the image is on the right, as Frankenstein, because Galvini and Aldini were both accused of having an interest in resuscitating criminals, seeing whether they could be brought back to life. And here you see a cartoon of the time that shows a galvanized corpse brought back to life with the devils in the background saying, "He's back amongst us now, he's not gone." The brain was studied by electrical stimulation throughout the 19th century. You have to see this as a paradigm. You have to see this exactly the same way as today we would talk about genetic changes or genomic changes or protein changes. When you try to understand a disease, you use certain tools which are particularly prominent in science at that time. And starting in 1809, stimulation of the cortex was one of the most important paradigms. So the names I'm sure you'll recognize: Rolando, Hitzing, Serie. You may not have heard of Robert Bartholow in 1874, who actually stimulated an awake human. In 1882, Sciamanda, an Italian neuropsychiatrist, actually localized sensory motor function in man. And a British neurosurgeon, Victor Horsley, studied the internal capsule, the motor region, and related structures. By 1900, the use of electricity was fairly, I don't want to say popular, but it was something that was done rather casually. It was called Faradayzation. And here you have a nurse who's applying faradic current to a patient. The first sporadic stimulations and medical treatments with electricity, speaking not about exploration, but treatments, go back to 1767 at the Middlesex Hospital in London, now closed. But the apparatus was purchased at St. Bart's Hospital 10 years later, and Guy's Hospital has a published list of cases from the 1880s, and the apparatus can still be found. This you may recognize from a few weeks ago when we looked at at shell shock and the treatment of shell shock during World War I. This was a so-called Bergonic chair, probably at the Maudsley Hospital in London, which is one of the major psychiatric institutions in Europe. During the 20th century, brain stimulation continued, both clinically and investigatively. And as you go from 1905 till about 1980, you find several important people that you may have heard of. First of all, Neminsky, who showed that an EEG could be printed showing cortical activity. Wilder Penfield, of course, the professor of neurosurgery and the founder of the Montreal Neurological Institute. And two names you may not have heard of who are really important. One is Robert Heath in New Orleans, and we'll talk about him some more, a very controversial character, unclear whether he was a visionary or whether he was a sociopath. And Jose Delgado in Spain, who's best known for very dramatic demonstrations of what stimulation could do. And by 1980, magnetic stimulation. But to really talk about this, it makes sense to start moving towards the treatment of mental illness and its understanding. So the key times were about 1900. By 1917, Freud began to talk about depression as a sense of loss, either real or imagined, and how to deal with it. The famous case is called the case of Hans O. And if anybody has an interest in it, it's absolutely worth reading because it's classic vintage Freud. By 1927, Wagner Jauregg in Vienna came up with a very interesting idea. He decided that mentally ill patients with syphilis, which was what general paralysis of the insane entailed, might recover after a febrile episode. This was clinical observation. He experimented with injecting streptococci and tuberculin, and then he concluded that the best way to induce a fever was with malaria. Malaria, after all, could be cured or at least controlled with quinine. And in 1917, he reported the first favorable results of the study. Syphilitic patients inoculated via intravenous injection of malaria developed repeated bouts of high fever and improved. In 1927, the Nobel Prize was awarded for the first biological treatment of mental illness, which was the inoculation of syphilis into patients with malaria. Also in 1927, Manfred Sackel in Berlin moved to Vienna and began the use of insulin coma. The idea of insulin coma was to get people on what was called a Winterreise, a winter's trip in Germany. It was used certainly for mental disease. It was also used a little bit later for pain and for other conditions. The idea was to get a hypoglycemic shock. Shock was considered a neurological event at the time, not yet a vascular event. And it required a tremendous amount of work because the patient was kept in a kind of coma for perhaps weeks at a time, in some cases 6 or more weeks. Here's a picture of 2 nurses feeding a patient who is in this state, and patients often seized. By 1957, 30 years later, this was eclipsed because of difficulty and lack of evidence of efficacy, and also because of the introduction of more effective medications. But by 1934, other ways of getting seizures were pursued. Convulsive therapy was started by Dr. Meduna in Budapest after Professor Niro observed that the rate of schizophrenia seemed to be lower in patients with epilepsy than the remainder of the population. And Meduna is often quoted as saying, if I can stimulate epileptic seizures in schizophrenic, then these will alter the chemical and humoral processes of the body in a way that the abatement of the disease will be made physiologically possible. The idea of causing a seizure to treat schizophrenia or any other kind of mental disease, including depression, was mostly abandoned by the 1940s, except in the USSR, where there's a very unfortunate history of using seizure therapy and electroshock for political purposes, as well as for medical purposes, well into the last quarter of the 20th century. In 1938, electroshock was introduced by Ugo Ceruleti in Italy, and this was electroshock for severe psychosis evoked by an epileptic seizure. I'm sorry, I said it backwards. Electroshock was intended to evoke an epileptic seizure, and the idea was explicitly to remodel neural connections. Electroshock replaced cardiazol. And by the way, for those interested, cardiazol is still used in part of Europe for resuscitation after cardiac events. After the war, electrical stimulation went in many directions. The best noted is pain control, leading to Meltzack and Wall's Nobel Prize for the gate control theory of pain. A very important character, and I use that word not at all reprehensively, is José Delgado, a Spanish neuroscientist, who undertook intracranial electrical implantation first in animals and then in humans for the treatment of medical disorders. He implanted about 25 humans, mostly schizophrenics, mostly schizophrenics and other mental illnesses. And he was known primarily for using things like radio signals to control the current in electrodes. In 1963, after a spell at Yale, he famously stopped a charging bull using radio signals. In retrospect, it's not clear that the bull stopped. It's possible that the bull just turned, but it was very dramatic and led to a number of attempts to implant electrodes in humans to control behavior, including violent behavior. It also led to ablative therapies, including amygdalectomies. We can't go into that today, but it's a fascinating history. In 1963, Bekhterev, a Russian, published on multiple electrodes implanted in the subcortical structures. And in 1960, some very regrettable experiments in electrical stimulation for the treatment of schizophrenia were conducted at Tulane University by Robert Heath. Again, it is unclear how much of what he did out of interest in the science and how much was done for the adventure. And he's a figure who is still, whose understanding is still debated. Starting in 1953, however, Advances in medicinal chemistry, neurochemistry, and psychotropic and antidepressant medications eroded interest in psychiatric indications for electricity, and scientific investigation in the implantation of electrodes and what was generally called psychosurgery gradually stopped by public concern. By 1985, it was all but abandoned in the US. I'm going to switch now to transcranial magnetic stimulation, which is really a different story, but it's electrical. So in that sense, it's certainly conceptually related. In the early 1980s, at the University of Sheffield in England, Anthony Barker developed the first attempts at transcranial magnetic stimulation. There was concern about seizure potential when he undertook experimentation to understand seizure potential and to activate corticospinal pathways. By 1995, clinical evidence for the use of transmagnetic stimulation as a diagnostic had coalesced, and also by the same time, the use of TMS in treating major depression first appeared. It was described as a treatment that had many of the benefits of electroshock therapy with almost none of the side effects. In 2008, the FDA gave approval for refractory depression treatment using transcranial magnetic stimulation. I'll just use TMS to refer to that. There was a double-blind, multi-site study of 301 medication-free patients, and very interestingly, a site was identified. And that site was the left dorsolateral prefrontal cortex. It had statistically significant improvement when compared to sham. The absence of sham procedures was one of the things that condemned previous attempts at electrical stimulation of the brain and psychosurgery. In 2008, Neuronetics, a company still in existence, gained FDA approval for the NeuroStar device, and repetitive TMS at high frequency was shown to produce excitation through long-term potentiation of the cortex. It also yielded clinically significant outcomes in treating patients with major depressive disorder who were recalcitrant to treatment or resistant to treatment. This is the timeline for the introduction of TMS. From 1984 to 2013, when Medicare gave approval, that was 2012, and 2013, when most insurers began to allow and to pay for TMS. A second treatment with BrainsWay was cleared in 2013, and now there are a total of 7 devices that have gained pre-marketing approval by the FDA. All except for BrainsWay are restricted to depressive disorders. BrainsWay is also approved for some other uses. The European authorities are much more liberal in what they allow in terms of transcranial magnetic stimulation. The machines are all very similar. They vary in cooling mechanisms, coil design and composition, and pulse widths, and it is uncertain how exactly these parameters influence outcome. Here are some pictures of some of the devices, and with the exception of the one on the lower left that looks like a hairdryer in an old salon, they all pretty much look alike and have a portable unit in a chair, a way of holding the coil to the brain, and means of keeping the patient comfortable. Mechanisms of action have been the focus of study by many neuroscientists since the 1990s. It's clear that TMS modulates neural processing. It's clear that cell membrane depolarization is a part of it. It is clear that the magnetic field depolarization affects a set of nerve loop activities, and that these are modulated in turn by stimulation frequency, duration, and intensity, and the target region. It's equally clear that some stimulus models induce prolonged effects on neural activity that survive the duration of stimulus. The last 3 points qualify to allow one to say that TMS exerts a biological activity. And by biological activity, we mean its dose, duration, and location modulated. And this is one example. This happens to be the NeuroStar example, and I'm using their system. I do not have any relationship with them or with any other commercial organization. The treatment coil in the NeuroStar produces the same magnetic field strength as a 1.5 Tesla MRI. The field pulses 2 to 3 centimeters in depth, and it depolarizes neurons locally and precisely. The physics, it turns out, are based on electromagnetic induction articulated by Faraday in 1831. An electric field produces a perpendicular magnetic field and vice versa. In TMS, the capacitor discharges an electric pulse through a copper wire coil embedded in a plastic case. The case is placed on the patient's head. The changing magnetic field induces an electric current. The magnetic field travels through the scalp and skull without attenuation except by distance. There are 3 basic coil designs. Circular and figure-8 coils are most often found. A is a circular coil all the way on the left. It produces a wider electrical field. You can stimulate both hemispheres simultaneously. The figure-8 coils are more specifically focused. Cortical neurons are selectively depolarized. The wider literature says 1.5 to 2 centimeters below the scalp, but 3 and 4 centimeter depths are claimed. H coils, which you see to the right, claim a broader and deeper and larger volume of energy field, but more importantly, they say it's introduced more efficiently with less need for cooling. Depending on the location, inhibition or stimulation can be induced. And this is a picture of the figure-8 coil just to give you a sense of size. There are several stimulus parameters that are used and several other experimental ones that have been described. The single pulse TMS is no longer so much used, but it is applied to a specific brain region to depolarize cortical neurons and trigger a motor evoked potential. This is motor evoked potential for diagnostic purposes. Paired pulse TMS generates 2 paired stimuli with identical or different intensities separated by an interval of several milliseconds, while in repetitive TMS, which is the most frequently deployed therapeutically, you have low frequency or high frequency pulses at millisecond interval, and pulse variation influences intercortical and intracortical excitability, intrahemispheric and transcallosal conduction. When I will be speaking about TMS from this point onward, I will be alluding to repetitive TMS unless I mention something else. One more note on mechanisms. The long-term effects of TMS, which extend beyond the duration of the stimulus, are attributable to synaptic plasticity and certain gene and protein expression changes, particularly those underlying NMDA receptor function. Change in plasticity are related to changes in membrane potential, and there are 3 causes which are generally ascribed. One is postsynaptic calcium influence. The second is potentiation or depression of excitatory synaptic transmission. And the third is activity and modulation of the activity of interneuronal inhibition. Magnetic stimulation influences local interneuronal circuits as well as other fibers, including fibers projecting down the dendrites antidromically or orthodromically down the axon to more distant structures. This turns out to be important, and when we speak about the circuit of Pepez in just a second, I'll mention that again. Research in these areas continues. Other plausible working effect hypotheses include effects on neurotransmitters, including serotonin, dopamine, and GABA, effects on brain-derived neurotrophic factors, and this is especially well studied in trauma, plasticity in the frontal striatal network, changes in the medial temporal lobe area, and general white matter excitability changes. There is also an interest in the effect on endocannabinoid, particularly in terms of the effects of TMS on pain. Now, we should just take a small excursus here and talk about melancholia or depression. Depression is the modern term, melancholy is the classical term, which is really what TMS is used for in psychiatric treatment more than any other area. The modern ideas of depression probably emerged between 1780 and 1880. Before that, and even early on, they were seen as a matter of temperament or character. And we talked about that a little bit when we talked about shell shock a couple of weeks ago. In the 1850s, depression was redefined as a primary disorder of mood when there were no delusions, that is to say, when it was not a psychotic depression. And between 1860 and the 1880s, very famous names in medicine and psychiatry came to regard melancholia with delusions the same way, as a primary disorder of the mood. This gave rise to studies about where depression and other mental illness might actually exist within the brain. In 1913, John Watson focused on behavior without anatomy, and behaviorism is still a very important strain in understanding psychiatric thought. In 1917, Freud modeled depression in terms of real or symbolic loss, and at least in one of his books, he begins to talk about what the neuroanatomy is of mental illness in ways that we no longer necessarily recognize as entirely relevant, but ways that are very telling for the time. Parallel work in anatomical and physiological bases for mental illness continued prior to World War II and of course afterwards. And in 1937, James Pepez, that should be a Z, formulated a theory of a limbic circuit for emotion that came to be called the circuit of Pepez. It's shown here on the right. Broca had earlier described the great limbic circuit, which is very similar, which Pepez never cited. And the circuit is the cingulate gyrus, the parahippocampal region, the subiculum, mammillary bodies, and anterior thalamic nuclei. Just a parenthetical remark, I spent a few years working on this together with other people at the Limbic Mesencephalic Laboratory in Boston. And what we found, to everybody's surprise, was that this was a very complicated 300 millisecond circuit with many, many inputs. And we couldn't quite explain it because that's not what the anatomy initially suggested. And it was only later when it was seen that there were connections to the prefrontal cortex, to the association cortex, and from the hippocampal formation to the mammillary bodies, to the anterior thalamic nuclei and thalamico-nuclear to singular connections, that people began to understand these pervasive circuits that this made this a much more complicated system than simply one limbic circuit. So why does all this matter? This understanding created the basis for possible stimulation targets for TMS. And people have looked at the prefrontal cortex for impulsivity, the left prefrontal cortex for pain and major depressive disorder in fibromyalgia, the vagus nerve for affective disorder, the right dorsal prefrontal region for PTSD, and general anxiety disorder. Remember, we're talking about here is a biological effect. Can you show that this is not placebo? Can you show that there's a biological effect? Dose makes a difference. Location makes a difference. Pulse stimulation makes a difference. Pulse parameters make a difference. In 2016, the European consensus study was published, and it looked at 3 levels of evidence. The contralateral M1 motor area was seen as a good target with level A convincing evidence, for an analgesic effect for pain. The left dorsolateral prefrontal cortex showed to be a very good target for depression. Level B data, more than a signal, less than convincing, showed left frontal cortex for, and contralateral M1, I should ask, for chronic motor stroke and for negative symptoms of schizophrenia, the same left dorsolateral prefrontal cortex stimulation as you might use for depression. And then again, the right dorsolateral frontal cortex seemed to have an effect for depression. Level C data, which meant this probably deserves study, but less convincing, is the left temporoparietal cortex for tinnitus and hallucination. And I'm sorry I don't have a pointer to use, but the left dorsolateral prefrontal cortex is the area that you will see shown unilaterally again and again, and also both prefrontal cortices for bilateral stimulation. After FDA approval in 2008, early reports started drifting in. Some of the early ones were small, 30 sessions in acute depression. Nobody was quite sure how long to stimulate. And there were two types of reports that were published. One used observer and one used patient-reported response scales for depression. One observer-based depression scale, the CGI Clinical Global Impression Scale, showed a response rate of 50.6 and a remission rate of 24.7% at 6 weeks. The Hamilton Depression Rating Scale was a little different, 41.2% response rate and 35.3 remission rate at 6 weeks. But here's the interesting thing, 49% of patients were subjected to maintenance therapy, less intensive, and 62% maintained their responder status. These were difficult patients who also were characterized by treatment resistance. And treatment resistance was characterized by a mean of 3.4 failed adequate trials of medication in the current episodes. The TMS treatment was well tolerated. There was a discontinuation rate of 3% in the acute phase, and there were no serious events observed. Other reports talked about TMS beneficial compared with sham for all outcomes. And the question was there a clinically significant, meaningful decrease on rating scales? And the conclusions were that patients treated with TMS were more than 3 times as likely to respond as patients receiving sham treatment, and remission was more than 5 times as likely to occur in patients receiving TMS than in patients receiving sham. That doesn't mean that it was maintained, just that for the period of time that that stimulation was given, response occurred and remission seemed to be placed for 6 months. A fascinating study looked at antidepressant activity versus sham or ECT, and this was published in 2016. There was a 10% absolute difference between TMS and sham, but in this type of patient, ECT gave better results than TMS. It was more efficacious, tolerated less well. And so the conclusion was that TMS has the best balance between efficacy and acceptability, although ECT is still a very important treatment. In 3,000 patients, more proof of biological effect was achieved. This was done by looking at the location of stimulation and also the paradigms. High frequency TMS on the left side was better than low frequency on the right side, better than bilateral TMS, bilateral than deep TMS, better than theta burst stimulation, which is another parameter, and better than direct current stimulation. Bilateral theta burst stimulation had no effect, and synchronized TMS had no effect. This was considered very important in the field because it gave witness to the idea of a biological effect. And in 2020, there was additional study of deep transcranial magnetic stimulation, not just cortical, around 700 patients. And an interesting finding that really will, I think, influence where we go from this point on, so that only studies using TMS, in this case deep TMS, and antidepressant medications achieve statistical significance. The TMS was invariably well tolerated. By 2020, TMS was recognized as a first-line treatment in the management of treatment-resistant depression. Between 210 and 220, in 611 patients studied with bipolar depression, there was a detectable signal of efficacy for bipolar systems, but bipolar treatments did not result in outcomes superior to sham. 10 studies reported cases of affective switching, meaning that patients with bipolar disease changed from a depressive affect to a manic affect without a clear pattern of potential risk factors. One can only conclude that in bipolar disease, current studies are inadequate, and this is an important area for further studies. Veterans are fascinated. The VA was very interested in this as a way of efficiently providing for patients with PTSD and depression. They were very concerned about suicide risk in the first 1,000-odd patients that were enrolled in studies. With PSD, the response and remission rates were 52% and 41% respectively. Without PSD, they're about the same, 54% and 36% respectively. But what the VA did not do was look at formal ratings of PTSD to see whether the PTSD itself was treated or affected by the TMS, and that remains to be done. Another area of great interest, first brought to the literature in 2016, was depression in pregnancy. Just to give you a reasonable figure, 15% of women are said to suffer postpartum depression, and the number of patients with prenatal depression, though perhaps not as well studied, is almost equally large, or at least equally significant. Many women who are pregnant do not wish to take medications, and many patients who are breastfeeding also do not wish to take medications. In a small Canadian pilot of 20 women compared to sham, 4 weeks postpartum, 75% of treated women were in remission versus 12.5 women in the sham control group. Non-invasive stimulation resulted in important differences in both response or remission in both antenatal and postpartum depression. Depression after stroke was an area that initially brought tremendous optimism to the rehabilitation community, but there is no convincing effect that we can look at. It may be effective for the treatment of the stroke symptoms itself and possibly cognitive deterioration, but the data are just not good enough to discuss. I'm not going to speak about electroconvulsive therapy, except to say that it is controversial and opposed both in the public eye by many and by many professionals, but the statistics suggest that there are specific mechanisms of dopamine and serotonin release to explain its effect. There are neurotrophic effects, there may be immune system modulation, and even though it's controversial, in selected patients, it has been shown to be effective. TMS is best tolerated and has the most favorable balance between efficacy and acceptability, but there was no difference in response and dropout rates between ECT and TMS in major depressive disorder in 1,300 patients with major depressive disorder. The study which has gotten a lot of attention over the past month is a study at Stanford that uses a form of TMS called theta burst stimulation with a remission rate of 90% after 5 days of open label treatment and a 5-to-1 improvement over sham. This will need to be repeated. Larger number of patients will be necessary, and the study will need to be repeated in other areas and other centers. But it is extremely optimistic and again speaks to the biological effect. If you look across large studies over the past 10 years, the response and remission rates are notably high, and they're consistent across self-report and clinician-administered assessment, and also across different technologies. Direct current stimulation is another way of stimulating the brain. It's not as well studied. It seems to parallel TMS in terms of treatment resistance. Interestingly, depression symptom severity, employment status, and refractoriness to treatment seem to be 3 major treatment failure predictors. This again is open to further studies. I want to now do a quick tour of further indications: phantom limb pain, traumatic brain injury, and the depression thereafter, cognitive deficits and major depressive order. All of these need further study. Multiple sclerosis is a very difficult area. Pain in multiple sclerosis, particularly trigeminal neuralgia, is a very interesting area of study. But this really needs more study. Good studies are really absent. The European Consensus Report highlighted pain and headache and suggested that in neuropathic pain and in primary headache disorders and post-traumatic brain injury-related headaches, there was high evidence for the use of TMS. In fibromyalgia, the strongest signals of pain reduction, fatigue, sleep disturbance, and points of tenderness. And it appears that TMS is better than transcranial direct current stimulation. Again, stronger studies are necessary. All of these studies, however, need to be put into the context of the risk that people fear, which is seizures. Because TMS for diagnostic purposes was related with seizures and thereby abandoned for a number of years, the risk of TMS-related seizures has been studied time and again over the past 24 years. The risk overall is less than 1%. TMS has been successfully used in patients with epilepsy, traumatic brain injury, and TMS-related seizures. The risk of TMS-related seizures is comparable to those of most psychotropic medications. What this does say, however, is that if you are performing TMS, the laboratory in which you do so needs to be able to provide resuscitative treatment and patient support. The overall seizure rate is 0.31 per 10,000 sessions and 0.71 per 1,000 patients. One particular coin design has a seizure rate which is significantly higher than the figure 8 coil devices, and this also needs to be studied further. There are no formal safety guidelines for direct current or alternating current stimulation. There's several emerging technologies that I'm going to mention, and with this, I'm going to end. Transcranial direct current stimulation seems to be effective in depression and post-operative pain, may be effective in other indications, with an effect size that varies very greatly, from 0.01, which is not, to 0.7, which is pretty impressive. But a real clinical impact study needs to be done over time. Deep TMS is under exploration for psychiatric and neurological indications, but also needs to include the idea of a focused TMS or sort of stereotactic TMS. Focal ultrasound is being developed by a number of researchers, most notably Pierre Mourad, professor of ultrasound in the Neurosurgery Department in Seattle, who believes very strongly that this may be a way of getting transcranial stimulation for cognitive disorders as well as psychiatric disorders. And there are no good data yet on the use of low-level light therapies, but that has been mentioned as even less invasive than transcranial stimulation. And then one last comment, clinical trial design in major depressive disorder and TMS. There are three methodological issues that if you look at the literature, one must look at time and again. The first is that the trials are often small. The second is that major depressive disorder should be defined carefully, but very often is not. And then the question is whether brain stimulation studies are different than other types of studies. And the answer is both clinical and statistical. Focus on sample size and power, assess and look at the degree of refractoriness of subject, articulate the primary hypothesis, the clinical endpoint and statistical tests, stratification, randomization controls, and strict eligibility definitions are critical. Adapt the study design to the target population. Consider adaptive and Bayesian study design, which has not yet been adequately done, and seek out enriched population using electrophysiological as well as biological marker techniques. And with that, let me thank you for your attention. And I am open to questions. I turn this over to our hosts. And Andres, how would you like to continue?
So if anyone has any questions, we can go ahead. We can have a few minutes. I don't know if Dr. Grewal had any comments.
Yeah, I'll start with some comments and then I'll leave it off to Dr. Miller who had the question. Dr. Dagi, thank you for a very insightful talk on kind of the history, but as well as the current state of minimally invasive or non-invasive neuromodulation for psychiatric conditions. I think there's a large focus on depression as we all feel we feel helpless sometimes in treating some of these patients. And, I think you really need a multidisciplinary approach working with our psychiatry team, our neurology team to do so. I think you very eloquently stated and gave credit to a lot of the psychiatrists in history who developed a lot of these circuits, these neuro circuits that we're targeting today. So, I think it's a wonderful talk and I look forward to seeing what we can do together here. I'll leave it to Dr. Miller and see what his thoughts are as well.
If I could make just one comment, one of the most important findings from the review of the literature is that the best outcomes are combined treatment by psychiatry and transcranial magnetic stimulation. That's number one. And number two, that patients need to be continued on medication during and after their treatment. This is a joint approach. It cannot be done purely thinking of the brain as something that you can stimulate with bolts of electricity. Dr. Miller?
Yes, and again, another fascinating lecture. One thing that I think I appreciate, but we're all impressed with, is your appreciation for and your understanding of the history of medicine. I've seen this in other talks you've given in our lecture series as well. It's really fascinating and really wonderful work. This is a very interesting field. My question to you is, you talk a little bit about, people looking at seizures to change cortical electrical patterns and things. And you talk a little bit about ECT maybe being more effective in certain situations and maybe giving a little bit deeper and longer lasting sort of reset, so to speak. At least it's talked about in different ways during your lecture. Is there any evidence for the fact of any real changes? Has anybody monitored this and looked? Are there changes in the electrical patterns in the pathways after this treatment?
There's a tremendous literature on that. It's more of a literature than I can summarize here, and I'd be glad to talk about this some other time. But it's clear, certainly in the TMS literature, that comparing TMS to ECT and sham, there are instances with major depressive disorder when ECT is better and certainly not inferior to TCS. And in many cases, TCS is inferior, but it's much, much better tolerated. So the publicity that has been attracted by electroshock over the past 90 years, almost 100 years, has been pretty problematic. When you actually look at the data, whether or not we understand all the elements of it, it's clear that electroshock does have a role in depression. The same way that ketamine is emerging as something has a role in acute depression. We can't go into it right now, but yes, I think there are very clear animal models of neurophysiological effect.
Again, thank you very much for the lecture.
Thank you.
Excellent stuff.
Thank you. Dr. Tatum?
Yes, thanks a lot. That was a wonderful presentation. I really, really enjoyed it. I was curious. I remember hearing about the SAINTS trial, and I was curious about the theta burst index. How is that obtained, and why do you think that's a distinguishing characteristic to result in improvement?
There are age-related issues having to do with major depressive disease and the outcomes.
It looks like here on this one.
All the studies just about.
And then it's much more posterior though, temporal. But
I'm sorry, I'm not quite sure. Is it okay to continue?
Yes, sir. Go ahead.
Oh, sorry. So age turns out to be an issue. All the studies so far have been done on adults, except for a couple of studies that have been done on children with very, very specific indications. So the age index is important here. And it's more than I can talk about right now, except that one of the things one has to look at is the length of the depression and the number of times that patients have been treated, and their refractoriness, which is defined in terms of refractory episodes, as well as the depth of the major depression. And I think that that's a secondary index, a proxy to some of those figures.
I see. Is the theta burst a setting on the machine, or is it a recording?
No, it's a recording.
I see. Okay. So it's a bidirectional type of device then that stimulates and records.
It's it does not all of them record. Some of them have the ability to record. They're stimulating machines. I thought what you meant, I misunderstood you, forgive me. I thought you meant was it something that was recorded in the demographics, and it's recorded in the demographics. It does not necessarily influence treatment. It is not a treatment modulating. It's not, say, let's say we would say that scalp thickness or something that would affect that would modulate the dose. It is not a modulatory phenomenon in that sense. It doesn't affect the dose.
Got it. Thank you so much. I really appreciate the talk.
Thank you. Dr. Grau?
Hello, do you hear me?
Yes, I can perfectly. Thank you.
Thank you. Thank you for your talk. I don't know if I missed that you are only going to talk about the psychiatric application. Just I wonder, two questions. One, what is your opinion about direct electrical stimulation for brain tumor treatment? And second, we're using TMS in brain tumors in two ways, trying to localize cortical areas before surgery, and second application, try to induce plasticity after treatment of brain tumor. What is your opinion on that application?
It's a little further afield than what we're talking about today, but I think the data on the initially Canadian and Israeli data on stimulation for brain tumor control is very strong, and the FDA has given pre-marketing approval for it. So I think large series data are being collected, and certainly for improving plasticity, one would think that the TMS model should be applicable also to the uninjured brain and other indications. The question is whether in the whole set of treatments that are given for brain tumors, the cortex and the deep structures are affected in such a way that TMS would not be effective? I don't know the answer to that. I just don't know. And I think that's something that can only be, the answer to that can only be attained by studies. As I sit here now, I can't give you an answer to that. And you're right, I apologize, but I couldn't talk about brain tumor stimulation in this shorter period of time together with this subject. Thank you.
Hello, Dr. Dagi. I wanted to thank you for your presentation. I just had a comment regarding depression, because we usually think about depression even as mentioning as an illness, which is not, because we don't know exactly what causes it. Depression can be many, many things. And I think that's part of the key issue here. As long as we don't have biomarkers to really define what depression is, it's very difficult to define the population that will respond to whether it's TMS or TDCS or DBS in this instance. So I think that's one of the major challenges that we have in psychiatry and neuropsychiatry, understanding the etiology of depression and which areas of the brain might be working or not. Are the circuits working? Is the electricity going to be conducted? Is this, molecular? Is this inflammatory? Is this vascular? And I think there's different approaches. So I think a lot of these techniques might have indications. But unfortunately, we've had them for many, many years, and then the rates of depression are still about the same. So I think if these techniques could help our role in defining the types of depression as biomarkers, that would be a very useful approach. So I wonder if you had any comments on that.
I love this comment. It takes us into a fascinating area of nosology, how you actually define a disease. For example, do we agree that neuropathic pain is something that we can call or define, even though we don't know exactly how it's caused? I think that there are many conditions, and I'm using the word conditions rather than diseases from a definitional and philosophical perspective, that we can't define using a biological marker for which biological markers are required. But we treat them anyway. Traumatic brain injury is a perfect example. We don't really have a biological marker, and yet there are physiological and anatomical characteristics that we might be able to call out. With respect to depression, I think it's absolutely true. We do not know what the disease actually is, and there may be many things that may result in depression without there actually being depression. What we're talking about here is not changing the incidence of depression, perhaps affecting the prevalence of major depressive disease, or at least alleviating the symptoms. And I think from the review of the literature, you might agree that even if we don't understand what makes up depression, even when we don't understand the cause, we can say that in certain selected patients, and we're not very good at predicting which those are right now, we need to find the enriched population. If we can identify them adequately, we can give up to 50% of them relief in the short term, and in a third or more, we may be able to give a long-term remission. And all I would argue is, insofar as the state of the science is concerned, this would be a significant improvement of the clinical situation, and we hope to learn more as we begin to study these patients. This is not something to be used glibly. We don't just turn around and say, let's give transcranial stimulation to every patient with depression. And they need to be studied. They need to be studied in a multidisciplinary way in an academic center. And the fact that there is reimbursement available for this is one of those things that makes it perhaps a little bit easier for people to select patients for treatment and to provide adequate treatment. But I think your point is very well taken and nobody can argue with it.
Thank you.
Well, I think we've reached our time. Dr. Dagi, thank you again for an excellent talk. We look forward to many more, hopefully.
Thank you very much. Thank you all for your attention. It's delightful speaking with you.